Good day, everybody, and thanks for this kind invitation once again. And unfortunately, this time I'm not in Dubai, but recording this talk from Italy. My job today is to give you an update on MRI and how to use MRI in MS. But I will focus mostly on the clinical side with some advance on some of the new methodologies or new markers that we can use in MS from some MRI and imaging perspective. These are my disclosures. No conflict of interest anyway in relation to the topic of this talk. And let's get into the real talk. We use MRI to help in diagnosis and eventually, to have a good differential diagnosis. There is anyway the possibility to use some more advanced techniques that could actually give us some neuroimaging biomarkers that could be very useful in terms of understanding the disease mechanism in MS, for example, but also in other neurological disorders, tracking disease progression and monitoring treatment. We try to do all of them in MS, and actually MRI has shown to be very useful. In this respect, as you know, there have been lots of different guidelines how to use MRI in MS. Recently, the three different groups of experts that they're experts in using MRI and MS put together in order to actually give for the first time the consensus recommendation on how to use MRI in patients with multiple sclerosis. The three groups were the Magnim's group, the Canadian consortium, and the North American imaging MS consortium that put together in a more than one meeting actually get this consensus recommendation. I don't have the time to get into this, and I don't want to focus my talk only on this, but one important message that is coming from this consensus recommendation is the need of using MRI for diagnosis, for prognosis, and for monitoring MS. But when we do this, and we want to do this in a proper way, we need to standardize brain MRI protocols for monitoring these patients. And when I mean standardize, I mean, standardize at least within patients, meaning using protocols that are very similar, timelines that are very similar, and sequences that are always constant over time. And eventually we can discuss about this. I don't want to focus the talk on and talk about something else which can be actually quite useful for you in terms of understanding how to use MRI in MS. One thing that we want to do when we use MRI is, of course, looking at the lesions. We know. You probably know very well which are the lesion characteristics, the sites. Still very clear periventricular, infratemporal, juxtacortical, spinal cord are always very important for the diagnosis and for understanding the MRI pattern, including the shape of the lesion, the distribution, which is always asymmetric, the evolution, which is variable in different, unfortunately, very variable within patients and between patients. But of course, what we want to try to do, particularly when we monitor our patients, is to uh, look at new lesions and looking at the subclinical, what we call subclinical disease activity in the patient, which can be the presence of new lesions or eventually enlarging lesions. This can be very difficult sometimes, and we use actually software that do these approaches like this one, and there is a so-called subtraction imaging. One time scan is subtracted to the other in order actually to make evident the lesions and quantify them through a real platform that can do these things for you and helping the radiologists in making a more accurate job. This is actually quite important. It's something that makes our life a little bit easier in terms of looking at the new lesion, and especially in the enlarging lesions. But of course, this can be done by eyes as well, and is definitely important in order to assess subclinical disease activity, which is important, as you know, in both cases, diagnosis, prognosis, but also, and of course, monitoring during treatment. Something that is becoming every day more important is trying to assess what we call slowly expanding lesions. These chronic lesions, as you see here, seen in T1, that increases over time. There are neuropathological evidence that tell us that the slowly evolving lesions, slowly expanding lesions, can be a candidate biomarker for smoldering inflammation in MS. So, telling us something about this chronic inflammation that is present underneath in this lesion, which is not the classical inflammation with which we see on MRI with gadolinium lesion, but it's something more subtle, but very important, not only in the in increasing the tissue damage on the brain on MRI, but probably important in the progression of the disease. These chronic active smoldering lesions can be actually shown also on susceptibility weighted image, which can demonstrate the presence of this progressive damage in MS, and together with this, the susceptibility weighted image can actually show the presence of the so-called central vein, which is very important for the differential diagnosis in MS, but also the paramagnetic rims, which that you see here quite well. Both of them can be are important. The second one can be important, particularly to tell us that some chronic inflammation is present, and something which is it seems to be related to the progression of the disease as well. As I told you, central veins and the presence of intra-lesional signal loss can be important in the differential diagnosis. This is both of them are usually not present, for example, in vascular lesions, as you can see in this table, but they are very frequent in demyelinating lesions. This two aspects of the lesion, together with the lesion size, the lesion number, the lesion topography, the location in different areas, can be important in order to have a characteristic pattern of the disease that could be classified as a demyelinating pattern compared to a vascular-based lesion like happens for example, in patients with migraine. And let me show you what I'm saying when I talk about, once again, central vein signs in MS versus migraine, in which you see there are the white arrows that on the top show the central vein signs, and no central vein signs in the bottom close to the lesion. Lesion on the migraine brain, which is much smaller, and is and without the central vein, and punctate to some extent. Something in terms of signal loss on the susceptibility weighted image. There is no signal loss in migraine. There is some signal loss in the lesions. The yellow arrows in this situation gives you the idea. On top, on the migraine brain, and on the bottom on the MS brain. So signal loss and not signal loss of central vein signs, together with topography, size, and other lesion characteristics, can be important. It makes making one of the most difficult differential diagnosis that we can have in when we want to to classify a patient with on the basis of MRI with multiple sclerosis. Very important thing that we need to take into account, in terms of making the diagnosis of MS, but also understanding the disease occurring, the pathology occurring in MS, is the presence of cortical lesions. These are important. As you know, in the new classification of the diagnostic criteria, cortical and extracortical lesions are both present. So, it's something that we need to do in terms of making the diagnosis. We need to take into consideration. It's definitely important in making a differential diagnosis, for example, because not many situations not many pathology can show cortical lesions, and usually these are definitely more frequent in patients with MS than in other possible disorders. But also it is important the fact that is telling us that gray matter and cortical gray matter is involved in MS, is important in terms of having a role in probably the progression of the patients, the disability of the patients, and the clinical aspects. Both at the early stages, but also in a sort of damage that could actually predict worsening in disability over time. And this is what is telling this paper, but also many other papers that associate cortical lesion load with progression of disability in 5 years in this study, but also in the long term, until 30 years now, in different studies telling us that the high baseline cortical lesions, high number of new cortical lesions, together with the atrophy that we're going to see in a minute, is definitely important. And as I told you, this is It's important also because it's telling us about something different of what we thought until a few years ago in terms of MS. It's telling us that the cortical pathology is important, and probably the meningeal inflammation present in our patients, has been shown by the ectopic B cell follicle-like structure, shown in many studies by Richard Reynolds and his group, are definitely important in order to explain the gray matter damage, the cortical pathology that we have in the patients with MS, but also explaining, some progression and worsening over time that we have in patients with MS in particular situation. And so the message is, look at the white matter in patients with MS, but to look also at the gray matter in terms of focal and diffuse pathology that we can have in this in our patients. So multiple sclerosis as a disease which involves both white matter and gray matter. But I can't stop talking about lesions without taking into account also the lesions present in the spinal cord, without telling you how they are important in terms of being responsible of the disability and the progression of the disease. You see here from this lesion probability map in patients with CIS, relapsing remitting, secondary progressive or primary progressive, how the lesions in the spinal cord lesions increase over time in the different phases of the disease, but also how the lesion load in these patients is very different according to the disability. Mild EDSS has much less lesion load compared to moderate EDSS, and even more the lesion load is present in severe EDSS. So this is as well important. But together with lesions, we need to take into account also what is what's happening in terms of diffuse damage in the brain of MS. And in this review of some years ago, we were actually discussing how this is important, not of course in terms of supporting the diagnosis in MS, but it's definitely important in monitoring our patients for treatment effective, but also in terms of monitoring and trying to predict disability in these patients. The truth is that when we have a patient with MS, this is on the right is a patient with secondary progressive MS. We compare that brain with a similar with a brain of an healthy control of similar age. You see the big difference due not only to the lesions, but to the white matter lesion, even the gray matter lesion, but the diffuse tissue loss that we have in patients with multiple sclerosis. And this actually starting in accumulating very early. And in fact, we can quantify it. If we assume that the brain actually is like a bottle of mineral water, as a healthy controls, it depends on the age. My age, I'm starting to to lose a little bit more than a little spoon of water per year. So it is definitely age dependent, but I'm assuming the age is the same. In patients with MS, we lose a little bit more than healthy controls in terms of of this water spoon, but of course, for example, in Alzheimer's disease, we lose a little bit even more. going into into percentage, we are talking about probably something like 0.5% or 0.6% per year, which is a good cutoff in between healthy controls and MS. Although this, we can discuss about this in terms of of the general how we can generalize this data to all the different contexts and all the different situations. Anyway, this is just to have a flavor of what's the situation. How will this can start quite early in patients with MS. This is actually important in terms of clinical disability, because there are a number of studies. These are only few of them, but that tell us constantly the same thing. Brain atrophy together with lesions are both important in terms of predicting long-term disability. So atrophy today is telling that we're going to have a much worse disability in 10 years, 9 years, 15 years, and in 13 years in all these papers that I'm showing to you. And there is another paper, very recent, that is saying the same thing in 30 years follow-up. But what is also constant in this situation is not only brain atrophy overall is important in predicting worsening, in predicting bad disease or worsening disability. But most of the damage and most of the brain loss is actually in the gray matter fraction, and talking about cortical gray matter, but thalamus as well. So gray matter is probably the location in which we actually get this atrophy, and mostly this atrophy. This is actually quite important, not only as we can see in this clinical study. This is actually a study on a follow-up on the clinical ground from the patients followed in San Francisco by Stephen Hauser and all his colleagues. It is important, as you can see, in patients who are worsening with relapsing, but also in patients who are worsening without relapsing, the so-called silent progression in patients with, who were disease activity free. So it's something which seems to occur independently of lesions to some extent, and independently on very evident inflammation, probably also related to that smoldering inflammation of what we actually discussed a few minutes ago. Of course, atrophy has been used in clinical trials in many occasions, and actually is becoming one of the most important endpoints, sometimes even primary endpoint in some progressive trials. It is actually something quite interesting to use. There are, however, some problems in using in clinical practice. I don't want to get into the technical and different factors. Most of them are technical factors, but also habits, comorbidities, physiological factor can actually be confounding factor in the use of clinical of brain atrophy in clinical ground, including the difficulties of making it. Well, we've been trying to overcome some of these difficulties, including making some normative volume. In this case, we have 5,000 in these slides, 5,000 different healthy controls, male and female, in both 1.5 and 3 Tesla, and we actually measure the different structure of the brain and provided the normative volumes for them. And in fact, we are providing some, think of what way-based assessment of lesions and atrophy for whoever it wants. And this is to some extent the first way of in making this available in terms of on lesion quantification and brain volume quantification, which could be helpful for following, in our view, for following monitoring patients with MS. Last 2 or 3 minutes of tell you that in terms of advanced biomarkers that we can use, also spinal cord atrophy is becoming quite interesting, quite important. This could be actually assessed very precisely and accurately today. Several studies have shown the importance in different phenotypes of MS and how actually spinal cord atrophy is actually evolving and over time in a different phenotypes, how this can correlate with the clinical worsening of these patients. So it's actually definitely important, definitely something that is going to become, I think, a measurement which is going to be important in the future. And in fact, actually, this is just been is used now also in clinical trials. The sample size, as you can see here, with the new approaches, it's very much better compared to before, and spinal cord is actually filling the gap with brain in the use of for understanding the disease, but also monitoring and the patients with MS will be used very much, I bet, in the future. This was my last slide. I thank you once again for the invitation, and I must thank also all my collaborators in my lab, but also the networks in all over the world with Montreal, Montreal Neurological Institute, the Mannings Group, and several other groups in Italy and in Europe. Thank you very much.